Hello, everyone, and it's a pleasure to be with you today. And I'm very grateful to Amira and the IMF team for asking me to give you some updates from ASCO and EHA. It's my privilege first to present to you some information from our pivotal phase 3 ICARIA trial, where we looked at some specific subgroup pre-planned analyses and presented those results at ASCO. Just to remind everyone, and my first slide shows this, the phase 3 ICARIA study was a randomized trial in relapsed refractory myeloma, where patients were assigned to either the gold standard at the time, which was isatuximab, which was pomalidomide and dexamethasone, or the experimental arm, which was isatuximab, pomalidomide, and dexamethasone. And basically, we assigned 307 patients in total to the trial. This was an international multi-center effort. Patients had received at least 2 or more prior therapies, and in fact, the median was 3 prior lines of treatment. And patients had to have run out of benefit from lenalidomide and proteasome inhibitor-based treatment. So as you can see, a substantial number of patients were lenalidomide refractory, and in fact, 94%, with 60% lenalidomide refractory in their last line. 77% of patients were refractory to a proteasome inhibitor, and 72% were refractory to both classes of drugs. So clearly a patient group of exquisite unmet medical need. And as you can see, the pomalidomide and dexamethasone platform worked as expected, with responses engendered in about 35% of patients, including some high quality responses. And these responses were generally durable, with DOR, what we call a duration of response, of around 11 months, at a follow-up of about a year. Encouragingly, the isatuximab, pomalidomide, and dexamethasone arm performed substantially better, with a response rate of 60%, so almost twice as great a response rate, and importantly as well, an improvement in duration of response. But what was particularly striking was what's shown on the right, which was a progression-free survival curve showing disease control was substantially longer for patients receiving the 3 drugs over the 2, with almost almost 12 months of benefit from the 3 drugs compared to around 6.5 months from the 2. Now, with that in mind, we presented at ASCO updates from the study for some pre-planned analyses, and this is what we call PFS2, which is just to make sure that if you use a particular triplet early and the patients then experience progression with subsequent treatment, have we in any way penalized their ability to benefit from long-term treatments in the future? So in other words, does the use of the 3 drugs early in any way penalize patients for benefit later? And what we were very pleased to see is that that's not the case. As you can see, for the 3 drugs, the isatuximab, pomalidomide, and dexamethasone, the median progression-free survival approached 18 months. And for the 2 drugs, the median progression-free survival in the second context, or PFS2, and subsequent to further relapse, was around 13 months. So the clinical benefit was sustained, and this was statistically significant. So there was a significant improvement in PFS2, as we call it, with the 3 drugs compared to the 2, so showing there's no penalty to using the isatuximab early, and the benefits is sustained. And then when we looked at overall survival benefit, we were very encouraged to see really encouraging overall survivals for both groups of patients, recognizing these are relapsed and refractory patients in which they've become truly double refractory. And so at the time that this study was conducted, constituted an exquisite unmet medical need. And what we were able to show is that the median survival for the 3 drugs approached 25 months, so well in excess of 2 years, whereas the median survival for the 2 drug assigned group was a little lower, actually, at around 18 months. And this obviously is a strong justification for using the 3 drugs over the 2. So while strictly speaking, this difference wasn't yet statistically significant, and there clearly was a strong trend towards that. So how does this compare to other combinations in the same setting? Well, it's worth noting there was very nice data from the Apollo trial, presented actually originally at ASH last year with some updates at ASCO and ER. And what the Apollo trial showed, this was led by Thanos Dimopoulos, was the use of pomalidomide, dexamethasone, and daratumumab also was better than pomalidomide and dexamethasone alone. But critically, this was in patients in whom they'd only received 1 to 3 prior lines of therapy. So the benefit was encouraging at 12.5 months for the 3 drugs versus 7 months for the 2 drugs. So around a 5.5-month gain. So very similar to what we saw with Icaria. Important caveat is that this group of patients were less heavily pretreated than the patients in our study. But nonetheless, very nice to see a similar principle panning out and showing benefit. So very much an affirmation of what we saw in Icaria. And then finally, there was very important data at the meeting on the combination of isatuximab with carfilzomib and dexamethasone. And I think that that's worth just mentioning because it helps frame what I've just shared with you. This was outstanding data presented originally by Philippe Moreau and then updated at ASCO by his colleagues Ivan Spitzka, Thierry Facon, and Roman Hajek. And what they showed was that there was a dramatic PFS benefit for the trial overall. That was Philippe's original presentation. But most importantly, if you looked at the high-risk groups pre-specified, for example, high-risk cytogenetics, older age, recognizing the challenge of safety for carfilzomib in that setting. And again, in this particular trial, that looked actually quite favorable. And then finally, if patients were particularly refractory or had multiple lines of therapy, how did the platform perform? And in all cases, isatuximab continued to secure significant clinical benefits. So the overarching message is isatuximab in relapsed refractory myeloma, whether combined with pomalidomide, compares favorably to daratumumab-based combinations in the same setting and clearly has clinical benefit. And at the same time, when combined with other backbone drugs like carfilzomib, performs really well. So we're very pleased by this aggregate of information. And certainly from a patient perspective, this is an exciting new addition, in my view, to our armamentarium that targets CD38 to derive greater clinical benefit for our patients.